was I think 2.2.
Yes, but because
So you entered full blade, so automatically the width become 2.2.
actually the lateral back cut give you an little amount of freedom, but measurement wise, as people are doing in MSICS society also, they're taking 2 millimeter, means they are talking 2 millimeter, although seemingly they are putting a 6 mm intraocular lens, which is unfoldable lens, but still calling that as a 2 millimeters.
Same thing with Bosch and Lomb machine when we used to do 1.4 millimeter incision.
Thank you.
Ultimately we had to make 2.2. Thank you.
Can we have the next presenter, Dr. Nivedita Das? Is Dr. Suresh Kumar Arya present? Okay. So we can have you next, sir. She has been standing for quite long. Okay.
Both these are not working? Both the podiums are not working?
Oh, it's not working. Can we have Dr. Nivedita's presentation, AVT?
From dislocation to clarity, managing an old traumatic anterior misplaced intraocular lens and corneal bulle. Intraocular lens or IOL dislocation is a known complication of cataract surgery, which may occur early or late, with an approximate incidence of 0.2% to 2.8%. Although posterior dislocation is more common, the anterior dislocation can be visually significant. Long-standing, unmanaged anterior IOL dislocation leads to complex anatomical changes, including haptic iris adhesions, corneal endothelial compromise, and anterior chamber instability. In this video, we are going to present a technically challenging IOL exchange surgery in an old case of anteriorly dislocated single-piece rigid IOL, complicated by iris haptic fibrotic adhesion, optic fragmentation failure associated with partial corneal endothelial decompensation. 50 years old Indian female presented with significant vision loss and irritation in left eye since past 1 year. Her cataract surgery was done in the left eye 8 years ago. She had a blunt trauma in the left eye which was managed elsewhere by conservative treatment. Her best corrected visual acuity at presentation was counting finger at 3 feet distance. On slit lamp examination, the optic of the IOL was seen forwardly dislocated, resting over the pupil, with incomplete view and orientation of the haptics. There is pupillary ectropion UV and iris pigmentary changes. Cornea has few epithelial bullae with localized stromal edema around inferonasal area. The endothelial count was 1545 per millimeter square with central corneal thickness of 580 micron. USGB scan showed normal posterior segment and pachymetry analysis revealed increased epithelial thickness at the inferonasal quadrant. Failure of the conservative treatment and the progressive corneal endothelial decompensation necessitated surgical intervention. Given the complexity of the case, the surgical plan was aimed at safe and atraumatic explantation of the IOL without further damaging the adjacent structures. Precaution was also taken to possible preservation of capsular support and secondary IOL implantation either in the sulcus or inside the capsular bag. Under peribulbar anesthesia, a side port was made at 10 o'clock position and dispersive along with cohesive viscoelastic were injected to protect the endothelium and to adequately deepen the anterior chamber. A dialing instrument was introduced at superior optic haptic junction of the PMMA IOL to dial it clockwise to make it free from the superior angle. But rotating the IOL further, it was noticed that the lower haptic has perforated the iris and densely fibrosed with it at the inferior angle. But repeated dialing remained unsuccessful. After injecting a little viscoelastic, pulling out the haptic from the entanglement with a microforceps could not help. Rather, a great attraction caused an iridodialysis along with fresh hemorrhage from the angle. Next, I try to cut the fibrous tissues wrapped around the haptic to make it free from the iris fibers with micro scissors and tried to gently pull with dialer again, but it did not work. At this moment, I plan to cut the inferior haptic from the optic by a IOL cutting scissors. Another side port was made at 2 o'clock position and previous one was enlarged. Viscoelastic was injected and stabilizing the inferior haptic with dialer. The cutter was used to cut the haptic at the haptic-optic junction and the optic was successfully separated. Now an attempt was made to bisect the optic by same IOL cutter. After injecting viscoelastic, main incision was enlarged. IOL is properly positioned and fixed with spatula. The IOL cutter was introduced, but it was difficult to grasp. Now the IOL was stabilized with micro forceps from the left side port. But the cutter was failed to bisect the hard rigid PMMA material even after repeated attempts. Now the incision was further increased to remove the whole optic along with one intact haptic. Although wasn't the original plan, but it was the safest path forward. Posterior synechiae was released from the capsular bag. And a +20 diopter, 3-piece IOL was put into the bag after checking for capsular integrity. The large wound was closed with tenonylon. Viscoelastic was removed and sutures were buried. Air bubble was injected into the AC. Localized anterior stromal puncture was done over the bulle. The hypertrophied epithelium was removed there and a BCL was applied over the cornea to remain for 1 month. Post-operatively antibiotic steroid drops and lubricant was prescribed. After 1 month, her corrected distant visual acuity was 20/40 with Manas 3.5 diopter spherical power. The cornea has a small area of localized edema inferiorly with endothelial cell density of 1340 per square millimeter and pachymetry of 541 micron. The eye was doing well after 2 months with a normal fundus and at 5 months with a stable distant visual acuity of 20/40. This case underscores 5 vital lessons for any anterior segment surgeon. Long-standing IOL dislocations may not follow the expected course and may end up with fibrotic tissue development even in quiescent cases. Preoperative imaging is essential but not infallible. UBM or high resolution anterior segment OCT may help, but prepare for surprises. Have multiple IOL cutting and explant strategies available. Don't rely on a single technique. Know when to
Thank you.
That's a very nice video, and the struggle was a lot.
Yeah.
So, knowing that the corneal endothelium was already compromised, why didn't you think of doing what you did at the last at the very beginning?
So this patient came from the distant places.
Lovely.
So I told the patient that we may need corneal transplantation along with these procedures, but they are not ready for the transplant. So I took a chance, and I have taken all precautions for during the surgery by giving elastics protections, and I told them that after the surgery we need another transplant.
But the vision is good, so the transplant is
vision
not
is good,
required. I'll be
that's
I'll be very cautious in keeping a BCL there for a long time.
Yeah, I have just taken for 2 weeks, sir. After that, I have removed.
Thank you very much.
Thank you.
Beautifully presented, Dr. Nivedita. Just one point. Usually when we talk about cutting the IOL, we do it in the center, in the optic. You cut it at the haptic because I know it got entangled in the iris. Yeah, it's got entangled. That's a good thing. But I think it would have been better if you would have included in the video that you had taken out that haptic. You were concentrated more on taking out the optic, that you forgot to show us that the haptic was still there. So you need to remove that. Otherwise, it was a nice presentation. And do you think PI could have a role in this patient, seeing the amount of peripheral anterior synechia that was there? And
A small AIOC dialysis I have not done.
you haven't done. Okay. Thank you so much. Dr. Sudesh Kumar Arya, you can present in that podium, sir. Dr. Dhruval is here. Yeah.
Should I start?
Yes, please, sir.
This was a case of 50-year-old male who presented with the peripheral corneal thinning and impending perforation. So initially we thought of doing therapeutic penetrating keratoplasty in this patient, but we thought of because therapeutic keratoplasty will require another PK later. So then we thought of doing a bone membrane transplant in this patient, and let's see what happens. So it was a routine bone membrane transplant. So you can see we took the donor cornea. So in the donor cornea, first we have to do the scoring or the marking all around after putting the donor cornea on the artificial anterior chamber. So once it is done, before that we have to remove the epithelium also. So once epithelium removed, then you have marked the Bowman's membrane all around. Then with crescent blade, we can very easily try to separate the Bowman's membrane from the underlying stroma. So here the precaution should be that one should not pull the Bowman's with lot of force, otherwise it will cut through. So with very gentle counter pressure, and after this getting the clear cut cleavage, one can very easily separate the Bowman's, as you can see. So we have to stain with trypan blue so that you can easily see that this is the Bowman membrane, not the stroma. So you can see upper part is stained with the trypan, and the inferior lower part also, that is towards stroma, that is also stained. So if there will be stroma, then it will not be staining. So it is only the Bowman's which will be staining. So this gentle separation is done. So we could take whole of the Bowman's membrane as a one full membrane, because there are very large peripheral perforation. So we wanted to put complete Bowman's membrane. So again we have to stain it so that you can identify that there is no stroma over that. So after that, this whole of the Bowman's membrane, after marking the size of the perforation or whatever area you want, so you can see here the peripheral nasal part of the cornea was clear. So we wanted to save this cornea for future so that this cornea doesn't require any replacement. So then this Bowman membrane was nicely placed over this thinning area, and AC was well maintained because there was no perforation. So we could very easily seal this, and all the sutures were applied, and over that we have to put the bandage contact lens just like in any Bowman membrane transplant. So this was the complete procedure of Bowman membrane transplant. So this patient, after 3 months, everything was okay. So this area nicely healed. So now you can see this has nicely scar has formed. Now there was cataract. So because we didn't do the therapeutic penetrating keratoplasty. So the central cornea remained clear. So that was the advantage for us. So in this patient, without doing any penetrating keratoplasty, so we could just do phacoemulsification. So you can see there were few adhesions at the site of corneal scarring, so where the Bowman's membrane was nicely taken by the cornea. So after doing synecholysis, we tried to dilate the pupil with viscoelastic. So now you can see pupil is almost 5-6 millimeter, that is sufficient for any phacoemulsification. So now after that, it was a routine phacoemulsification procedure, but only problem was part of the cornea was covered by the corneal opacity, so visualization was definitely difficult in that area. So just by tilting the globe, we could do phaco nicely. So you can see CCC is being done nicely with the forceps, because if it extends in the area of opacification, then you will not see the edge. So best will be not by the cystitome, it will be best by holding with this micro forceps, so that you can have edge all around. So nicely CCC could be completed. Then after that, of course, hydrodissection. So we have to be very careful that, because if you keep the cornea central, then you will not be able to see lens clearly. So we have to tilt the eyeball slightly on the nasal side so that we can see exactly. So this incision also was made temporal so that we can see and perform all procedure very easily. So after doing all this hydrodissection, hydrodelineation, now this divide and conquer technique was used so that we can easily bring out the pieces. It was grade 3 cataract. So you can see this phaco was done, and there was no problem except visibility in the nasal part, which by tilting the eyeball we could see and bring the pieces on the temporal side where the cornea was clear. So all these pieces, they were nicely taken and eaten up. So you can see nice glow also was there. So after that, routine this irrigation aspiration was done. So again, taking care that on the nasal side where there is a corneal scar, there we have to be very careful. Rest of the area, it was routine irrigation aspiration of the cortical matter. And postage capsule was nice and axis was okay, so everything was as planned, so there was no problem. So we were just a little bit slow so that everything is taken without any damage to the posterior capsule, because we don't know what is there on the nasal side. So with the very little slow process, putting viscoelastic all the time so that our capsule bag remains inflated and the AC also remain deep. Then we implanted this foldable lens. So this was a 3-piece lens so that it nicely goes in the back. So we could implant the lens very nicely and there was no problem. And post-operatively, this patient could get 624 vision after surgery. So in spite of scar, so advantage of this BMT with in this patient was rather than TPK, patient did not require any further optical keratoplasty, because if you could have done TPK, then patient would have required another surgery in form of a therapeutic graft. So in this patient, we could just perform BMT and we could give good vision to the patient after doing phacoemulsification also. So that was the end of surgery. Thank you very much.
Thank you, Dr. Arya. Very nice presentation and a new idea. So basically, this is an alternative to lamellar patch graft.
Yeah, definitely.
So how it is superior to patch graft? Is it the surgical ease?
Yeah, actually, if there is too much thinning of the cornea and loss of tissue loss is there, then definitely this BMT will not help. But if you find the superficial loss is there only, so then BMT does play a very good role, and you can maintain the integrity of the cornea very nicely. In fact, we have done almost 20 patients with Bowman membrane transplant, and we have found it is very good replacement of therapeutic graft where thinning is not too much. Because that rest of the cornea you can use for other lamellar surgery.
Scientifically, I don't understand how does the Bowman membrane helps in the resolution.
Pardon?
Scientifically, I don't understand how does the Bowman membrane transplantation helps in taking care of the infection.
Infection? I'm not sorry.
I'm saying.
Actually, voice is not clear. It's echoing.
I'm saying I'm not sure how did the Bowman membrane transplantation helps in resolution of the infection.
Actually, infection is not going to resolve the infection. For that, you have to give the conservative treatment like 45 drops. It was a bacterial corneal ulcer. So all the treatment that you have to give. That 45 vancomycin that was given.
So was there a perforation or thinning
Of?
in the cornea?
Perforation, yeah.
Was there a perforation?
There was no perforation.
There was no
It was
perforation.
impending perforation, so that's why we planned. If it would have been perforated, then of course we would have done a therapeutic penetrating keratoplasty.
Did you consider alternatives like cyanoacrylate adhesive?
TABCL.
If you consider adhesives like cyanoacrylate glue or
Did you
something
try
like that.
Yeah,
TABCL?
actually it was a very large area of thinning. So there a cyanoacrylate will not help because that is good for 2 to 3 millimeter area of thinning. But it was
We cannot change it from one slit lamp to another. We have to use it in that slit lamp itself. So one of the cheaper and effective solution is to use mobile adapters for slit lamp. Now the problem with these kind of adapters are that most of them are only compatible with specific phones which are having a single camera. So now as our technology is evolving and when we are having a mobile with 3 to 4 cameras, it is very difficult to equip them. And the other problem is that it gets permanently attached to the one of the eyepieces. So you always have to look through the mobile screen and we cannot look through the eyepiece. So the only solution I could think of was designing a new adapter which addressed the drawbacks of the previously mentioned models. The next question for me was where should I attach this adapter? So this magnification flipper becomes very much far from the slit lamp, so I cannot attach it there also. And this IPD mechanism differs from slit lamp to slit lamp, so we cannot attach it here also as it cannot deal with the universality. So I thought that I will attach my adapter just behind the eyepiece. So after few calculations and measurements, I came up with a design of the adapter, which is this one, in which you have to just pull the eyepiece little bit out and you have to place the adapter below the eyepiece. And it can be fitted over with just 2 screws. Now this is a metal plate which we have to attach behind the mobile, and we have attached few magnets in the adapter, so your mobile gets automatically stick to the adapter. So once you get a good focus, you have to just flip it back on the eyepiece and you can use the slit lamp and even record the videos. And whenever not in use, you can just flip it back and use the slit lamp as you were using it before. So now the advantages of OmniView AS over other adapters are it is portable, plus you can easily install it with 2 handle screws. It deals with the universality. You can even attach it to the microscope or side scope anywhere, and its ability to flip back when not in use. Plus, your mobile is not permanently attached. You can take your mobile whenever not in use, and you can digitalize the whole OPD with this in a very cheaper cost. You just need to keep one mobile and you can use it for multiple slit lamps with the same adapter. You can even record foreign body removal, NDR, capsulotomy, iridotomy, gonioscopy, laser procedures. You can attach it everywhere wherever there is a side scope. So it is very cost effective.
These are corkscrew vessel scenes in carotid cavernous fistula. This is blood-stained Slem's canal. I have recorded during colonoscopy. This is neovascularization of iris 360 can see the movement of the vitreous cyst. This is neovascularization of the disc captured via 90D. So now this looks just like a this is a capillary hemangioma, but once you zoom in, you can see the movement of the RBCs, the rouleau formation very clearly. This was something rare for me to see, and this is a very rare video in which we can see the movement of the RBC in the blood vessel of the retina. It is a post PRPI. Thank you so much. So just a few points. So the key USP of this slit lamp adapter is it captures the 100% light. Unlike all other adapters which only captures the 30% or 50% light, because they are beam splitter based. Affordable price, it is only hardly 3,000 or 4,000 rupees, you can print it. It provides the best image quality, and you can digitalize your OPD fully with this adapter. It is portable. You don't need to shift the imaging system. You can shift the patient to the you can shift the imaging system to the patient rather than taking the patient to the slit lamp, and it is a smart flip and magnetic system. So
No, this is not a demonstration. Everything should be in the video.
it's okay.
Yeah, so that's
Thank
all.
you.
So suppose, doctor, I say that this is old wine in the new bottle. Like there are multiple these smartphone adapters. What is so special that we would like to purchase one for our clinic?
Yes, so the main USP is any other adapter, if you attach it, it permanently occupies your eyepiece. So you cannot use the slit lamp separately, and you cannot use the mobile separately. But it has the ability to flip it. So once not in use, you can flip, and it is magnet based, so you can use your mobile just after that.
Can it be used in higher side type slit lamp?
It can be, for now it is only compatible with
Zeiss type.
no, both. It can be, it is eyepiece based, so we can modify the eyepiece. I have even recorded ILM peeling videos in the OT. I have attached it to the side scope of the OT also and tried to record.
Thank you. Thank you very much. Nice.
Thank you.
Nice presentation.
Our next
Should I
speaker
start?
is Dr. Alka Pandey.
Okay, so good afternoon, everybody. Today I'm going to present some of the rhexis challenges which we face in a glaucoma patient. So we can have a shallow AC if there is a bleb and it was an angle closure glaucoma. And in such cases, the iris tends to prolapse. So instead of using a cystitome, because it carries the risk of endothelial damage, we should use a rhexis forceps, and you should frequently fill the anterior chamber with viscoelastic. Also, the pre-existing bleb should be saved in all cases. You should not injure the bleb. So that is very, very important in a glaucoma patient. Now, pseudoexfoliation cases usually have glaucoma. You can see there is zonular weakness in pseudoexfoliation. So you have to be very careful. You should use small strokes while doing the rhexis. Shouldn't be doing it very fast. Use small shearing forces and avoid large pulls. You can use a CTR also in severe cases because usually the lens is subluxated. Now, glaucoma patients usually the pupil doesn't dilate, so you can use a pupil dilator ring. So this I'm showing a Malugin ring being used. So this ring is it's a safety pin like a ring, and it dilates the pupil up to 6 mm. So it's very easy to use. Now this is a BHEX ring, our very own Indian BHEX ring. This is also very good, and it makes the pupil hexagonal, while the Malugin ring gives a round pupil. So this is also useful in glaucoma patients to dilate the pupil while doing a rhexis. So you can see the ease of doing. Now in lens-induced glaucoma patient, there is high intralenticular pressure. So first, preoperative mannitol injection, of course, you have to give. So we puncture the anterior capsule with a bevel down 26G needle, suck in the liquid cortex to decompress the bag, and then we extend the rhexis with a forceps. So first we make a small rhexis. The rhexis is made in 2 steps. First we make a small rhexis, then we enlarge it, so that the bag is thoroughly decompressed. Also, after the IOL insertion, if you see the rhexis is small, you can further enlarge it. Thank you.
What is new in your video?
Sir?
What is new in your video?
Sir, I have seen people usually use pupil dilator hooks. They still don't use the Malugin ring or the B-hex ring for dilating the pupil. One thing. Second thing, in glaucoma patients, the chambers are very shallow. So when we are doing a phaco, we have to be very careful to fill the chamber with a viscoelastic and use a rhexis forceps instead of a cystitome.
Thank you. Excuse me.
You
Nothing.
can't ask actually. Sorry.
Oh, you're judge. I'm sorry.
Oh, please come. Acha. एक और लगाइए.
Yeah, then please provide a mic because.
Yes, sir. It is easy, sir, but the cystitome, the hub of the cystitome, the edge, it can touch the endothelium if the chamber is very shallow. And these days we have a side port rhexis forceps. Yes, sir. Yes, sir. Sir, yes.
You can use a micro-rhexis forceps.
Yes, that's what I said.
You
From
can-
the side
from
port,
the
we can
side
insert
port,
the
yeah.
Microforceps you can use.
Micro-rhexis.
You can also use the viscoelastic like viscoat sort of thing, which protects endothelium.
Yes, sir.
Yeah. Thank you. Thank you for the presentation.
Okay, Dr. Rangaraj, I think he's in another session. So we have Dr. Mishra Gaurav, Professor Nitin, Dr. Amrita. Oh, Professor Nitin, you are there. Do we have Dr. Amrita also? Yeah, you can be ready in the next podium, please. Professor Nitin?
Ma'am, can I start?
Yes, please.
It's not coming there.
Please click it.
ऑडियो ऑफ कर दीजिए फिर ऑडियो ऑफ कर दीजिए Good afternoon. I'm showing a video case of a congenital lower lid coloboma which was treated at our center. It's a standalone case. We get a cases once in a year, 1 or 2 cases. So this case was recorded, and I'm trying to elaborate the surgical technique which has been done. It was a 18-month-old child was brought with a history of defective lower lid. It was a lower lid coloboma. There was no other ocular abnormalities. We decided to evaluate the case on table and operate. Medial canthus was checked. In the lower lid coloboma, what was more important is to check how much is the defect, and can you have either a medial or a lateral limb of a fibrous tissue, which is a tarsal plate, where you can take the suture. It is not where the defect is ending, but where you are able to find the place where you can take the anchor suture. After identifying where the planned suture will be taken, the coloboma is excised, raw areas, and it is freshened up. In this case, I planned for the tensile semicircular flap. How much is the tensile which will be done was marked. After applying the traction sutures at the medial and the lateral end of the fibrous tissue or the tarsal tissue, remnant of the tarsal tissue, the coloboma was excised. As you can see, in this case, the lid guard was placed to protect the corneal tissue. Coloboma was excised, and after achieving the hemostasis, vertical mattress suture was planned. To avoid the tearing of the tissue or the cut through of the traction suture, the relaxing incision as well as tensile semicircular flap was fashioned. The movement of the tissue was checked and the vertical mattress suture was applied. As you can see, the vertical mattress suture was applied, and it was suture was applied without traction. After achieving the good correction or the good apposition at the coloboma end, the tensile flap was closed. Lateral canthus was formed with the non-observable 6-0 nylon suture. It was a nylon suture where it was sutured with the periosteum, and the tensile was closed in 2 layers in the as you can see with the 6-0 vicryl. The main aim is to achieve the closure at both at the tensile as well as coloboma edge without having the undue pressure or the undue traction over the sutures. That will help in healing without without any problem. Cut through sutures are quite common. The skin in the child 1.5 years is slightly elastic. Even if you can achieve the closure on the table, it should be without traction. After giving the vertical mattress, the skin was closed as the normal in 2 layers with 6-0 vicryl. Skin was with the 6-0 silk, and the long end of the mattress suture, vertical mattress, as well as the first suture was taken into the in the knot so that it will not abrade the cornea. So the post-operative follow-up was done. Sutures were removed after 5 days. The lead mattress suture was removed after 3 weeks in this case. My aim was showing this video, though it is a standalone case and coloboma we all operating, I am also oculoplastic trained, is that such cases can be done by a general ophthalmologist, and we give it to our junior specialist as well as trainees to assist. Vertical mattress, coloboma, repair of post-traumatic lead defect, doing a tensile semicircular flap, which is very easy, and many specialists, even junior specialists, are afraid or hesitant to do the flaps, basic tensile flap. So this is a case in a young child, 18 months old, where the good surgical outcome was achieved of the coloboma repair. Thank you.
Thank you for nice presentation. How do you assess the length of the relaxing incision on the temporal side? How much length it should be?
When you make a defect, or when you in case let's say there is a lead trauma or there is a lead tissue loss, or in such cases, when you measure how much is the gap or the defect, tensile curve should be of the same size, so the lead moves comfortably. It is not that just you make a vertical U or smile or something, whatever it is. From the lateral edge to the other end of the vertical, the defect which you are going to create, or the defect which is already there in case of trauma or lead loss, it should be the same so that the lead moves comfortably.
Thank you very much. Any question?
Just like to make a comment.
Sir.
You know, when we judge, there is a great emphasis laid on the cinematic content.
Okay.
So in a competitive video section, we expect that there will be a video, we expect that there will be an audio, and we also expect that there may be some music, plus minus. So why did you choose not to incorporate audio in your video?
If you see that initially when I was presenting and when I had made at home a few weeks before, so I had incorporated the music, but while transmitting it has been there. It was some audio issues was coming.
The audio? The voiceover?
I didn't put the voiceover.
Thank you.
Thank you, sir.
Dr. Amrita, Goshan.
Next.
Good afternoon, everyone. Today I'll be presenting a video on fluorescein dye and its application in ocular surface. Audio, please. I have an audio.
Audio volume, please.
Dynamics of the dye, the mechanism, and various clinical application. The standard method of applying a fluorescein dye is through sterile, single-use fluorescein impregnated paper strip.
Can you restart the video from start with this audio?
Of proparacaine fluorescein dye on the ocular surface, where it stains, where it doesn't, and why it matters. Fluorescein dye is a simple yet powerful tool for diagnosing a range of ocular surface disorders. In this video, we'll explore the dynamics of the dye, the mechanism, and various clinical application. The standard method of applying a fluorescein dye is through sterile, single-use fluorescein impregnated paper strip. Saline or 0.5% of proparacaine is placed onto the tip of the strip. Any excess dye on the strip should be gently shaken off to prevent overstaining before applying it to the lower palpebral conjunctiva. Fluorescein absorbs blue light at 465 to 490 nanometer and emits green fluorescence at 520 to 530 nanometers. A cobalt blue filter is used to excite the dye. Adding a yellow filter blocks the scattered blue light and enhances the contrast, making the green fluorescence stand out more clearly, as seen in these slit lamp images. The corneal epithelium consists of multiple structured layers: basal cells anchored to the basement membrane, suprabasal wing cells, and superficial squamous cells. At the superficial layer, the important tight adherence junction create a semi-permeable hydrophobic barrier which has molecular components that regulate cell-to-cell adhesion and permeability. In contrast with the hydrophilic nature of the fluorescein dye, it allows selective passage of tear components while normally preventing fluorescein penetration. In scattered damage to the superficial epithelial cells with loss of tight junctions, these cells may undergo apoptosis or desquamation, resulting in focal uptake of fluorescein. The staining appears as multiple small dot-like areas, each representing the site of superficial cell loss or disruption. These are what we call the superficial punctate keratitis. In contrast, a true epithelial defect represents a contiguous area of epithelial loss, exposing the underlying basement membrane. Fluorescein pools uniformly in this denuded zone. Additionally, microcystic edema presents as negative staining, where fluorescein outlines the elevated cystic space but does not enter them. Moving on to the clinical implications, fluorescein can differentiate staining patterns seen in superficial punctate keratitis. In Thigerson superficial punctate keratitis presents with multiple coarse round to oval epithelial lesions that stain with fluorescein. These lesions are often central and bilateral. Microspiridiosis presents with coarse raised white epithelial lesions that show irregular fluorescein staining. More extensive epithelial involvement presents as confluent staining in true epithelial defects. For example, in this patient with post-penetrating keratoplasty, there is a near total epithelial defect. Seedles can also be performed to detect a leak. This video shows Seedles test being performed on a leaking desmetocele. As we move further, limbal stem cell deficiency can be diagnosed with a fluorescein stain. In this pattern of stippled conjunctival staining, fluorescein stain can also reveal a demarcation line separating the clear cornea and the stippled cornea, indicating a partial LSCD. This helps us assess the extent of LSCD. In advanced LSCD, the corneal surface appears dull and irregular, which is lusterless, often showing stippled late fluorescein staining. Dry eye evaluation involves both functional and structural assessment of the tear film and the ocular surface. Fluorescein dye helps visualize the tear meniscus along the lower lid margin. It's a crude method to assess the volume of aqueous in the tear film. In a normal eye, it's around 0.2 to 0.4 millimeter, while in a dry eye, it's less than 0.25 millimeter. Another dynamic method to assess tear film stability is the tear breakup time, or the T-butt. After instilling the fluorescein dye, the patient is asked to blink several times to evenly spread the dye. T-butt is then measured as the interval between the last blink and the first appearance of a dry spot on the corneal surface. A value less than 10 seconds is considered indicative of tear film instability. In direct assessment of tear secretion, fluorescein dye helps assess real-time lacrimal gland function by highlighting the tear production. To perform this test, stain is gently applied to the superior palpebral conjunctiva near the lacrimal gland opening. The patient is asked to blink normally. The appearance and movement of fluorescein streaked tears on the ocular surface is observed. The timing, length, intensity of the fluorescein trail helps assess the real-time secretory response of the lacrimal gland. In this patient with Sjogren's syndrome, fluorescein staining in yellow filter before cautery revealed temporal, nasal, inferior and superior conjunctival grade 3 staining, which improved post-cautery. Another undiagnosed entity of dry eye is the hidden lid viper epitheliopathy, which is a friction-related damage. In the image on top, we can visualize a widened strip of staining along the superior lid margin associated with conjunctivocalluses and grade 2 bulbar conjunctival staining. Interestingly, the lower lid also shows a lid viper epitheliopathy, which is relatively uncommon finding. It's equally important to recognize the broader spectrum of ocular surface disorders. Redundant conjunctival folds may disrupt the tear film. Fluorescein highlights these folds by pooling between them, often seen near the nasal conjunctiva. Filamentary keratitis presents as strands of mucus and epithelial debris adherent to the corneal surface. Fluorescein stains the base of these filaments, vividly highlighting them. In Stevens-Johnson syndrome, the keratinized surface of the lower lid margin appears elevated, causing negative fluorescein staining. The lid margin keratinization can also lead to mechanical trauma of the cornea. In VKC, giant papillae form on the upper lid. Staining of the central core indicates an active papillae. Finally, a last note on infections. Dendritic ulcers are characterized by linear branching pattern with terminal bulbs which are highlighted by the fluorescein stain. In conclusion, fluorescein staining is more than just a diagnostic tool. It acts like a magic wand for the clinician, revealing what the naked eye cannot see. From subtle tear film instability to epithelial defects, keratinization, and infections, highlights the hidden disruptions on the ocular surface. This simple dye brings clarity to complexity, illuminating the path to precise, targeted care.
Thank you, very well presented. And in case of fluorescein staining, did you not miss its subtle foreign body in a subtarsal foreign body or some kind of, even the micro foreign body on cornea, if you are not able to delineate it on a slit lamp examination, the slit lamp highlights it. So that is one of the important things that it was missing from your.
Sure, sir. I think.
Thank you very much.
Thank you, sir.
Nice presentation.
Did you use the music? The music is from where?
The music is from this website where we can ask them permission to
So
use
it's a creative
Yes,
this thing,
yes,
common license?
Yes, you have to ask them permission. Thank you, sir.
The next speaker is Dr. Bajaj Ashish. Yeah. And do we have Dr. Nitin here? You can be present over there for the next presentation.
So, good afternoon.
Dr.
all.
Bajaj.
So, I'll be presenting a technique known as XNIT for SFIL, it can be done easily by anterior segment surgeons. It was proposed by the Arvind Eye Care Group.
For scleral fixated intraocular lens known as X-NEED technique. The case discussed involves a traumatic cataract following surgical aphakia.
Volume, please.
AV team,
For
the
scleral
volume.
fixated intraocular lens known as X-NEED technique. The case discussed involves a traumatic cataract following surgical aphakia. First, the vertical diameter of cornea is measured and the center is marked. Two conjunctival flaps are created at the 3 and 9 o'clock position. After which any bleeding is cauterized using bipolar cautery. Then partial thickness scleral grooves are created 180 degrees apart and scleral pockets are performed in opposite direction to accommodate the haptics of intraocular lens. And then a biplanar incision is made between the 6 and 7 o'clock position to accommodate the AC maintainer. Now the next step involves creating a superior cornix based flap. The bleeders are cauterized. Then scleral incision is made using 15 number blade and lamellar dissection is done by the crescent blade to construct a triplanar corneoscleral incision. Which is followed by 2.8 mm keratome entry into the anterior chamber and the incision is enlarged. Which is followed by a side port entry at 9 o'clock position using lance tip. The iridocorneal synechia are broken using Sinskey hole. Then 1.5 mm measurement is taken on caliper and marked at 3 o'clock position on the sclera. Then a 26 needle bent at its hub is inserted 1.5 mm from the limbus through the left scleral groove and exteriorized through the scleral tunnel. The leading haptic of 3-piece rigid IOL is docked into the needle and retrieved from the scleral groove. To prevent the haptic from slipping back, a silicone stay stopper is placed over it. The trailing haptic is similarly retrieved from the right scleral groove . After the trailing haptic is exteriorized, it is tucked into the scleral pocket. The silicone stopper is removed and the leading haptic is also tucked into the scleral pocket. Then the centration is adjusted as desired. Then the scleral grooves are sutured with 8 0-vicryl sutures to secure the haptics in place. Then the conjunctival flaps are also sutured.
You can also cauterize these flaps if you want, or place glue if required. Some people also leave the scleral pockets unsutured, but just since it's a secondary implant, so it's better to suture the pocket.
Finally, a single 10-0 nylon suture is applied to the scleral tunnel. And the side port is hydrated. The advantages of the X-knit technique includes its simplicity and safety, a reduced learning curve, and it is easy to perform by anterior segment surgeons. Thank you.
Nice presentation. So basically, two things. Did you do vitrectomy or not anterior vitrectomy?
This was already a vitrectomized eye, sir.
Okay.
So the advantage why we have shown this video is because initially in our center only SFILs were being done by posterior segment surgeons. But this technique is relatively simple because you need an AC maintainer. You don't need to put in a trocar. And it can be done by anterior segment surgeons. So we have started training our fellows also, so that SFILs can now be done by anterior segment. So it is actually not our technique. It's been proposed by the Arvind Eye Care group, Dr. Prabhu Bhaskaran et al. So we have started using it recently, and it's quite an effective technique.
Yeah, it's a good technique. If you don't use glue at all, you have given suture instead of glue?
Yeah, we are using glue also, sir. This was one of my initial cases, so just to be on the safer side, I've used a suture there.
But if you make this tunnel by a 16 gauge needle, then you don't need glue.
Yeah,
actually.
you might not.
Or you even don't need to suture it.
Yes.
It's a good technique. Okay, thank you very much.
Thank you.
Next, Dr. Nitin. We have Dr. Angaresh sir here, Venkatesh sir. You can present next, sir.
A very good afternoon. And so my video is on lenticular axis for self procedure. Modern refractive corneal surgery has had a multitude of new generation laser assisted lenticule extraction procedures in the last 10 years. Currently we have SMILE, which is the small incision lenticule extraction, Smart Sight from Schwinn Eye Solutions, Clear Z8 from Zimmer, and the smooth incision lenticule keratomelusis from Johnson & Johnson. Laser-assisted lenticule extraction procedures involve a small incision in the stroma followed by lenticule removal, thereby avoiding epithelial defects, postoperative pain and dryness, faster wound healing, and greater functional optical zone. Elita Silk is the latest new generation femtosecond laser from Johnson & Johnson Surgical Vision. It has received CEO approval for smooth incision lenticule keratomelusis. The advantage of Silk over other lenticule extraction procedures are it has low energy of laser pulse, which is 40 to 90 nanoseconds, small spot size of 1 nanomicrons, ultra short pulse duration of around 100 to 200 femtoseconds, and ultra fast pulse frequency of 10 MHz. The techniques of lenticule removal are lenticulorhexis, hemicirculorhexis, push and peel, and posterior dissection, anterior peel. So in the first video, we see the lenticulorhexis procedure where first the laser is given, and now you can see how we go with the peeling of the lenticule. We go in the direction which is shown by the arrows, and then the lenticule is extracted. In lenticulorhexis, the energy optimization of the laser is very important. This enables us to remove the lenticule without any dissection and just by peeling. Here you can see that with the forceps we enter and we dissect out first the plane in which the lenticule is present, and then in a clockwise manner the lenticule is peeled out from the stroma. Once it is peeled out and removed, then it is just checked that whether it has come out completely without leaving any tags. Hemicirculorhexis. Once again, here we begin to peel the lenticule from one side like the clockwise manner and to go halfway and then go on the other direction in the anti-clockwise manner and then go all around, and once it is completely separated, then the lenticule is brought out of the stromal tissue. In the push and the pull technique, we push the lenticule to the other side halfway and then peel the lenticule first on one side, that is in the clockwise manner, and then in the anti-clockwise manner, releasing it from all sides and then extracting it out through the 3 millimeter opening. Here you can see that we have dissected out and created a plane, and once we create the plane, the lenticule is pushed forwards on either side and then it is moved in the clockwise manner on one side and then the anti-clockwise direction. Once it is released from all the sides it is extracted out and brought out of the stroma. In the posterior dissection anterior peel, what is done is the lenticule is first dissected in the posterior plane, and this makes it easy then to just do a rhexis of the anterior plane, and we can just peel out the lenticule very easily from the anterior aspect. So to conclude, silk enables consistently smooth and easy removal of the lenticule without any tags of remnants of the stromal tissue. Silk decreases the corneal aberrations thanks to the biconvex nature of the lenticule. Due to very close laser spots, the lenticule is easily removable, and due to a very small spot size and low energy delivery, lenticule dissection is very easy. Silk involves less of dissection and more of lenticule peeling, hence visual recovery is very fast. Thank you very much.
Thank you very much for your nice presentation. Looking very simple, but I think it's very difficult to master the technique.
Yeah, so the important thing is the energy optimization.
Yeah.
So if you have the optimal energy, then it becomes very easy to peel out the lenticule rather than dissect it out.
So when you are peeling with the forceps, it is constantly rubbing the stroma, back surface of the anterior stroma. So will it not cause any opacity or some clarity will not be compromised?
So
because there is very little space for rhexis.
When you compare to peeling to
and
dissection,
the pulling, yeah,
there is a lot of difference. Like when you dissect out the lenticule, then the amount of the stromal bed becomes a little bit more uneven. So the recovery is a bit longer. But if you peel it out, then the recovery is faster.
Okay.
So the idea of doing peeling over dissection is to get faster visual recovery and to reduce the amount of higher order aberrations.
Thank you. Any question, Dr. Saab?
No, he's looking at you.
Thank you.
For any questions?
Thank you very much.
Thank you so much. Next we have Dr. Venkatesh. And do we have Dr. Mishra Gaurav here? He's not there? Okay. Dr. Venkatesh, you can start, please.
Is the audio on?
A passionate glaucoma fellow, brimming with enthusiasm and captivated by the diverse possibilities of minimally invasive glaucoma surgeries, or MIGS, and their wide-ranging applications, prepares to perform her very first MIGS procedure, after thoroughly studying the basics of MIGS and with several weeks of dry lab and wet lab training. Bubbling with excitement and hope, the fellow gets ready in the operating room. She carefully positions the microscope and the patient to achieve a clear on-face view of the angle under the Swan-Jacob gonio lens. To her dismay, the trabecular meshwork appears so faintly pigmented that she lacked the confidence to proceed with the surgery. Adding to her uncertainty, she was unsure whether she had effectively enhanced the outflow channels. Feeling sad and disappointed, the fellow leaves the operating room and opens up to her mentor, sharing the challenges she faced during the procedure.
Today, I performed my first independent MIGS case. However, I struggled to clearly visualize the trabecular meshwork as you do. I also found it difficult to assess the episcleral venous wave, identify vessel blanching, or observe the movement of the blood column in the collector channels. Could you guide me on what I could have done differently?
Don't get disheartened. Remember, slow and steady wins the race. But today, I want you to meet a very special friend, Mr. Blue.
Hi, my name is Mr. Blue, and I am here to help you. I have been your trusted companion, helping you stain the lens capsule to perform the capsulorhexis with ease. I've also assisted you in staining and visualizing the functioning bleb while performing cataract surgery on a post-trabeculectomy patient. Now, it's time for you to take a look through the Swan-Jacob lens and see how I can help you visualize the trabecular meshwork and perform a little magic along the way. See how much clearer the trabecular meshwork is after the dye application? Now you can easily pinpoint exactly where you need to perform the MIGS procedure. What if, during a procedure, a surgeon could visualize or even predict the outcome right there on the operating table? Sounds fascinating, doesn't it? But is this really possible, especially when performing MIGS, which involve such delicate, tiny structures within the eye? Let me share some evidence to show how I can help you achieve this. A short case series on KDB goniotomy, published by Daniel et al. In 2018, concluded that trypan blue can be safely utilized to confirm both aqueous outflow and the patency of Schlemm's canal and aqueous veins during canal-based glaucoma surgery. A study published by Rao et al. In 2023 found that trypan blue staining in more than 2 quadrants after GAT or microincisional trabeculectomy can serve as surrogate predictors for the need for medications. I wish you all the best.
Convinced by the evidence given by Mr. Blue and feeling confident, the fellow attempts BANG, KDB, and Tinito microhook goniotomy. Now that we've performed the trabecular excision procedure, let's see if the dye flows through the collector channels now that the resistance has been removed. I'm so excited! Let's take a look. After tilting the patient's head back to the normal coaxial position, the microscope is focused on the nasal episcleral vessels. Trypan blue dye is injected into the anterior chamber, and the flow of dye through the episcleral veins is carefully observed. Yes, the dye is flowing out in the quadrants where excisional goniotomy was performed. This is amazing!
Dye is injected, flows the test. Success is near, we're at our best. Lentival vessels open wide, blue dye flowing, we're on the right. Surgery's a success, we're feeling proud. Bleed blue, the future's loud. Bleed blue, the vessels are open, it's all true. Bleed blue, success is near, we're breaking through.
The fellow follows up with patients in the post-operative period, correlating the intraocular pressure drop with the clock hours of the episcleral venous wave observed. The best outflow patterns were seen with KDB, followed by the Tinito hook, and then BANG. The number of clock hours displaying venous outflow correlated well with the post-operative IOP and medication reduction, which is currently under prospective analysis. We also utilized these videos to counsel patients, demonstrating how the MIGS procedure enhances aqueous outflow. This visual approach significantly improved patients' understanding of the procedures compared to previous methods. Hence, we recommend all budding MIGS surgeons to use our long-trusted friend Mr. Blue to make their life easier. See it to believe it.
Thank you, sir. It's an excellent video and excellent videography, cinematography, and so the idea of a trip and below, it was an accidental or just you had some?
From that couple of evidence which we highlighted at that, so they were looking at the outflow, but the staining of trabecular meshwork was very accidental because in mature, I don't stain normally, but whenever you have a significant cataract, when you stain, then you saw that staining was going to the trabecular meshwork also. So it looked much better to see when it is a faintly pigmented trabecular meshwork. So that was an accidental observation, but the outflow has been reported as small case reports in case series. And now we are trying to do a prospective study to see whether you can find from the number of clock hours, the IOP drop and all. But it's very difficult to predict. The study is going on, but it was not accidental. It was, somebody has already reported that.
Thank you.
Usually it is done while cataract surgery is being done. Is it so, or it can be done?
You can do standalone also.
It can be a primary glaucoma surgery?
But mostly, most of our procedures have been combined with cataract.
With cataract, yes.
Yeah. Even if they have early cataract, you get rid of it so that your chamber also deepens and your procedure becomes much more safer.
Visualization of trabecular meshwork is more better in
the angle also deepens, so it becomes safer to do whatever you're doing with your blade or knife or whatever.
Otherwise, in a deep chamber, it can be done primarily.
Primarily also you can do in an open angle, correct.
In phakic patients.
Any angle closures, it's nice to get rid of the cataract and then do it.
What is the cost of this blade?
So the KDB is roughly 25 to 30,000 for one. And
disposable, or you can use 4 or 5 surgeries?
It is for one use. But
single use?
Yeah, single use. But if you carefully ETO it, you can use it for a couple of times more. But they don't recommend for more than one use. Because sometimes the tissue can be there. The trabecular meshwork can be there inside the blade. So you have to carefully wash without damaging the sharpness.
Nice video, nice video.
So is there any difference in the use, like per se, for the concentration of the amount from the previous descriptions that have been published? Is your technique slightly different? That is my one question. And the follow-up is that because you are not now staining the angles, and you also would like to see the dye flow out through the episcleral, so the amount would be more. Would you have concerns about endothelial toxicity of the dye?
Absolutely no. It's the same concentration which you normally use for your staining the capsule. No, it's the same dye, same concentration you are using. And of course, if you are using it for any ocular surgery, it's the same use here also. So we have not seen any damage because of the blue happening either to the angles or to the endothelium.
But have you done an endothelial cell count or something to see that?
We have done previously not for this particular work, but lot of studies comparing, where you use mature, brown, white, comparing SICS, phaco. We have done endothelial cell loss. We have not seen much after a Trifan blue use.
And the difference with what's been already published with your technique, is it same, or there is some modification of the technique?
No, this particular work which we are prospectively looking at it, we don't know exactly now, but the interim result says that with the clock hours of whatever you see with the blue dye, you can predict the IOP, especially in mild and moderate glaucomas.
Thank you. Very well made video.
Thank you. Thank you.
Thank you so much. With this, we come to an end of this session because Dr. Gaurav Mishra, he is not attending the
He's
conference.
absent, yes.
He is not coming. So we conclude this session.
You conclude this session.
May I request all the judges and the speakers, if they are present here, to come forward for a group photograph before we dismiss.
Thank you very much.
Thank you, sir. Very nice.
I'm not a student.